Okay. Okay, you're back live. Can you show us the final results or a new case?
No, we actually have moved on to a new case now.
Okay, great.
So you saw the final result on that one. All we did was put a short self-expanding stent, the way Chris said, and we'll show you the final result later. It's not an issue at all. It was beautiful flow. I wanted to show you this particular case, which is very akin to the lecture that we're doing. And I think what we should do is start with the presentation and then go to the lectures because they kind of tie in. So Dr. Singla is going to present the case very quickly.
Sure. Good afternoon, everybody. So we have a SFA chronic total occlusion case. A 64-year-old man with a...
the slides are going on and off here.
So I'll just go kind of extempore. So he's a 64-year-old man known to our service, hypertension, diabetic. He's currently smokes some dyslipidemia and worsening right lower extremity claudication for last 3 months. Had an ABI of 0.67 and on the left was 0.88. Now he did have an intervention done at outside hospital about 2 years ago, and we got pictures, and he had looks like a supera put in the mid SFA. We did a duplex there and in our facility, and it showed the occlusion of the stent and the proximal SFA also. So we gave him a trial of Pleatal, and over the last 6 to 8 weeks, we increased the dose. He was able to tolerate without any relief. And he told us that he went to another facility where they tried opening it up, but they were unable to do that. Today we brought him back to the lab knowing that he has a SFA occlusion, severe claudicant, walking less than block and a half.
Okay. So Giancarlo, I just want to go over the angiogram with you. So if you look at the angiogram, if it's playing, the iliac vessels are okay. They did a stent in the outside institution. The iliac vessel stent is fine. So then if you look at the SFA, you can see that you have a long segment occlusion, which in our opinion looks thrombotic. So, and then distally, you can see you have flow in the distal vessel all the way down. So then what we did here was, because they had trouble crossing from above, we felt that they got underneath the stent. We prophylactically just put a needle and put a wire in the dorsalis pedis, in the anterior tibial right here, just to ensure in case we get back into the same dissection plane, that's what's going to happen. So we have a wire access with no sheath, no catheter in the anterior tibial artery. So then we went ahead and I want to show you. Oh, this is the foot shot here. You're going to see the foot shot. So you see the foot shot shows he has robust 3-vessel runoff and really no issues in terms of placing that wire there. So we decided to go with the Viance catheter to try to stay within the center of the lumen. So we started wiring with the Viance, as you can see, and it's basically a fenestration catheter. I don't know if Dr. Wiley spoke about it, the fenestration catheter that tries to find the channels. And we didn't want to get underneath the actual stent because that was their mode of failure. They actually got underneath the superior stent and couldn't re-enter. They could have either stuck it or not, but they didn't do that. So here what we did was we stopped proximal, and we'd use the prolapse wire technique because what happened was the Viance kept getting underneath the superior stent. So rather than stick the stent here, we said, let's just try this. And Dr. Kapoor actually did this, was able to prolapse the wire within the stent. So at this stage, once we got the prolapse wire within the stent, it's always important technically for everybody in the audience to do multiple views to make sure that you're not behind any of the stent struts. So we weren't behind any of the stent struts, so then we went ahead and then confirmed our position distally. Sorry about that, now it should work. Confirmed our position distally, and you'll see that in a second, or maybe not. Let's go to the next one. And then we did an intravascular ultrasound. So play the IVUS, guys, because it's very important for them. The wire was going very, very smoothly, and you could see here you have a lot of speckled thrombus. There was not an issue with the Viance. We weren't meeting any resistance when we were going down. And what we were worried about, as you can see by the IVUS, there is a thrombotic component along with an atherosclerotic component. So in this type of cases, at least our algorithm here at Sinai, Giancarlo, is to go ahead and do some sort of aspirational therapy. In this case, we decided to do a angiojet therapy with filter protection. We know our distal vessel is, so our plan is going to do the angiojet protection and then come back to you to see how it looks. So maybe now you can go on to the next lecture or any comments. We're going to get started.
Okay, thank you for this great introduction and already the demonstration that it was relatively easy to pass this very long occlusion. And then I can ask Dr. Lee to speak about crossing and re-entry device use.
So Giancarlo, I wanted to show you what we did. So at this stage, we went ahead and did a angiojet. And as you can see, when we were doing the angiojet, we were able to clean out the stent pretty good. The stent was full of clot here. And you can see as we were coming down at this area, there wasn't really much of aspiration other than some clear substance. I think this is all in-stent restenosis or restenosis. In this area, I believe there was a lot more thrombus in this area, and we were able to really clean this area out. And then distally, you can see that it was much better. So when we inject, now we don't have a chronic total occlusion. Rather, we do have a channel now, which I think was very thrombotic if we had just gone ahead and ballooned it with what we had done. So we put the intravascular ultrasound in. Can you show the IVUS, guys? Yeah, sure. And when you see the IVUS, you can see that distally we've now got a much bigger channel. However, the dissection planes are there from the crossing that occurred, but you can see there was a lot more less clot burden, especially in certain areas. And then when we start getting into the stent, again, you see you still have that layered thrombus, which worries me a lot. And so at this stage, I wanted to kind of pick the panel's mind and see what they would do. I mean, I think in my mind, at least, the options would be to lyse this patient or to go ahead and do intervention with a balloon angioplasty or laser or something like that to see what happens. So I was just curious what the panel thinks and what they would do in this kind of situation.
Hello, PK. This is Jos. I think you're still dealing with a mixed kind of plaque here. There might be some more organized thrombus, so the risk of dilating at this point is probably still high. I think I would have preferred in my institution to start with lysis or go directly with a debulking technique, either laser or jet stream.
Right?
Yeah. And why not to predilate with a small balloon, with a short balloon?
Just PTA?
Yeah.
I think the risk of distal embolization is pretty high in this case.
He has a filter inside.
But looking at the IVUS, I think there are still some areas that might be prone to distal embolization.
So PK, this is Chris. The clinical scenario was, he's had claudication, but he's had attempts at the outside hospital. So this was not acute limb ischemia. This was claudication. Is that correct?
Yes, absolutely.
So I think you've got a mixed bag here. And, maybe up front, if we had the Rotarex that they have in Europe that has thrombectomy and that, or the jet stream or laser kind of gets all three components, maybe that's another choice. I think now that you've already done the angiojet and you've got a combination of plaque, dissection and everything, and he's still not an acute presentation, now it's a tough thing. And the other thing you could consider is ballooning now with distal protection, see what you get, and then decide from there. One option would be, and I'm not a frontline guy for this to begin with, but a Viabon strategy gets all of those as well. The dissection, the debris, the long lesion, that's not a bad option either.
So Chris, I think I know we have to go to another lecture. We have one more lecture, I think. So I think what we're going to do here is I agreed with Dr. Biamonino because we have a filter in place. So what I decided to do was to go ahead and place a chocolate balloon. So this is a chocolate balloon, and I think what this is going to allow me to do is expand this mixed bag, including fibrosis. I think that if I do embolize, Chris, and the panel, what I would do here is do the aspiration with the penumbra device, come forward, and or leave a lytic catheter or drip lysis. I think I'm ready to do that, and I think we have the expertise to do that. So I think at this stage, I'm going to go ahead and just go with a 6.0 chocolate balloon and just do balloon dilatation. I know it's longer than what Dr. Biamonino wanted, just because this lesion was completely occluded. So I think at this stage you can see there's some atherosclerotic plaque there. So we'll leave this up, and then we're going to go ahead and come back to you after the next lecture to show you how this turned out and how it. Oh, we can keep going. Okay, great.
Okay.
So,
thank you. Then we can switch to Leipzig. Yeah?
Actually, can they switch? No, we have time, Dr. Biamonino, because what it is we have a section here for this. Till what time is this section end? Till 3. So we have another 5 to 7 minutes here.
Okay.
and then we'll go to Leipzig.
Okay.
So we'll just go ahead and show you how this looks after the balloon. And I'm curious here, what would everybody's final therapy be here? Say this balloon turns out that it's nothing, or we have minimal embolization. Go up here, and then would somebody do a DCB or a DES in this particular case?
I think your post-chocolate angiogram is going to tell you what to do next. If there's a lot of dissection, then you're going one route. If there's a lot of debris, you're going another route. If it looks pretty good, then you could, all options are on the table, including DCB.
Prakash, this Jose, did you consider a pulsing spray that we've used in the past?
We thought about it, Jose, because we weren't expecting this to be in this manner, completely occluded down. So therefore, meaning thrombotic. So therefore, what we were very surprised at what we had with the IVUS and the ease that it crossed, as Dr. Bienvenido said. So I think at this stage we're dealing with a thrombotic lesion. So we could have, we could have done a pulse spray, but let's see. We did the angiojet to prevent it, and I think we'll know. I hope we don't live to regret that. We'll see now. So you can see this area is really atherosclerotic the way it's expanding. And I think the chocolate balloon is nice because it limits dissections. So let's see how this looks. Okay, down. Heart rate, guys. All right. So he is responding with a little bradycardia. I know, but he went down a little bit lower. So we're just going to walk this out and take a quick picture. And then I think if it looks good and we don't have dissections, we're probably going to scaffold this with a Zilver, Chris. That was our initial plan. We'll see how it looks. So always when you walk this stuff out, worried about thrombus, watch the filter as you're coming out. And I think it's very, very important to do that. Yes, sir. No, I'll just do a regular run. Okay. Mag out? Yeah, I think you just mag out and just do a regular run. So we're just going to do a regular run here in the last few minutes here just to see. Inject. Yeah, it looks like we have some poop down there. Let's see. No, I think it's all recoil. Don't you guys agree?
This is extreme recoil. This is more a re-occlusion.
Yep. So give us a. So I think Professor Bienvenido, I think we're going to go ahead and place a Zilver PTX now, because I think our mechanism of failure is a recoil. 70140 Zilver, please.
How far will you go down, PK, do you think, with your Zilver? Where do you start?
I think we're going to stop. We're going to start around 25 to 26, right? That's what we were told. And I think we're going to start at that stage, Chris. And you have that competitive flow around 25, 26. And then we're going to go ahead and decide how this looks after the Zilver. I'm certain that we're probably going to end up embolizing a little bit more. And then at that stage, if we have to aspirate, we will. But I think that's part of the idea of predicting what's happening through the available imaging modalities that we have here. So as you know, the stent, I mean, we're eager to see what the Imperial trial shows. But clearly at this stage, having a drug-eluting stent is definitely advantageous to us. My only question is, how do you guys stent within the Supera? How do you size the Zilver PTX within the Supera rail?
He wants me to stay here.
Did you hear that question? How do you guys stent within the Supera? When you do another stent, do you stent or you just balloon the Supera and leave it alone? How do you deal with the sizing of the nitinol stent with Supera?
It's going to get to the point of the Supera and stop. That's, you've got that limitation. There's not much you can do with it. If your Supera itself looked okay, you may end this stent just into the Supera and then start from the proximal end of the Supera, rather than put nitinol inside there.
All right, deploy. So we're going to go ahead and deploy this. That's one of the questions I think a lot of people have is how do you deal with that problem of having a Supera that's restenosed, and now you're going ahead and putting another stent in when you're not using another Supera. So I think this is an issue, and hopefully this case we don't have to do that. The other thing we thought about is just cutting it and using a DCB within the supera, which also may be possible. And ideally speaking, it would be nice if the supera was clean and didn't have any associated restenosis inside it. Because you saw with the angiojet, the supera was moving very freely, which is suggestive to me that there was really no interval hyperplasia within the supera. So you can see the expansion is quite good there. So we're gonna go ahead, walk this out, and again, watch the filter very carefully. And I think it's almost time to go. So what we'll do is we'll come back at our next case and we'll show you the result of this. Before the common femoral case, we'll take a few minutes and show you exactly how this turned out. But I think it's important for everybody to see that the options of dealing with thrombus in SFA lesions is a very real deal, especially when you have restenosis.
Thank you.
Thank you again, Dr. Bimanino. Thank you.
Good work, guys.
Then now we can go to Leipzig.
So give me a little back. Second patient that Dr. Metzger was also part of the panel was the SFA in-stent restenosis, which was thrombotic. So we had done angiojet, and then we had a discussion regarding what to do next because there was no flow. Dr. Giancarlo and I felt that there was more of a recoil issue, so we went ahead and decided to put Zilver PTX, and you can see here with our final picture, there was excellent flow. The IVUS showed there was some grumous material in the mid SFA stent that you'll see here. So we did not balloon angioplasty that spot. You'll see it in the next runoff. We did not balloon angioplasty that spot. Rather, we decided to put the patient on anticoagulation and then followed by ultrasound right at that spot right there. So it wasn't free moving, and we felt that if we had angioplasty, we would have sent it distal and made this patient worse. But from no flow to now, very good flow, and I'm sure good relief of symptoms. So. Again, I just wanted to give a full update, but I wanted to now take you to this case. We're back in room 6.